Hi everybody, welcome to this set of notes. This is the next set of cardiology notes that I'll be covering today. So these are all high yield facts that are from my Anki deck that I downloaded off of Reddit, and that's available for free on Reddit, and it has 7,000 cards. It's called T's Anki. You may have heard of it already. So far I've been loving it, so I highly recommend it. So let's get into the points now. Bullet point number 1, what are the non-pharmacological interventions in patients with hypertension? Most effective to least effective. Most effective is going to be weight loss if obese. If not obese though, you want to do DASH diet. The next ones are going to be exercise, decrease sodium intake, and watch alcohol intake. And then the distractor is going to be smoking cessation. It's not been shown to reduce blood pressure significantly, but obviously you should recommend discontinuing smoking to reduce overall risk of cardiovascular complications. Next point, what is the recommended cooling technique for patients with non-exertional heat strokes? The key is non-exertional. If it's exertional, then you want to do ice water immersion, but since this is non-exertional, you want to do evaporative cooling, so spraying lukewarm water while fans blow air on skin. It presents similarly to exertional heat stroke, but typically affects elderly patients in the absence of strenuous activity. So remember, non-exertional, of course, they're not going to have, they'll have a heat stroke, but it won't be when they're exerting any effort, whereas exertional, they'll be exerting effort. What is the only type of shock that is associated with decreased afterload? This is easy, I know you know it. This is septic shock, so this is decreased SVR. Decreased afterload means increased cardiac output. What is the likely diagnosis in a young active patient that suddenly collapses while exercising and presents with a temperature of 106, confusion and respiratory distress? That would be exertional heat stroke. So exertional heat stroke is defined as 104 degrees Fahrenheit or greater, but be careful with that because on NBMEs I've seen it be lower than 104 and it still be considered heat stroke. So just be careful. And CNS dysfunction, other signs of end organ damage organ damage may be present, and the key is not to give antipyretics such as acetaminophen and NSAIDs. So you do not want to give acetaminophen and NSAIDs. Oops, sorry. So do not give antipyretics like acetaminophen and NSAIDs. Medications that can cause heat strokes include anticholinergics, antihistamines, and TCAs. So remember this one more time, I'll repeat it one more time. Heat strokes can be caused by anticholinergics, antihistamines, and TCAs. So look for that in the history. All patients with acute coronary syndrome should receive 2 antiplatelet drugs immediately upon arrival in the emergency room. Those should include aspirin and a P2Y12 receptor inhibitor such as clopidogrel, prasugrel, or ticagrelor. It does not apply to chronic or stable CAD. ADP receptor inhibitor prevents expression of G2B3A receptor, so there's no cross-linking. Sorry, I don't really know what that means. I don't know why I put that point there, so just ignore that point if it doesn't make sense to you, because right now it's not making sense to me. Next point is that there's viral myocarditis, which can predispose the patient to dilated cardiomyopathy. What type of heart failure will be seen in these patients? You'll see systolic heart failure or eccentric hypertrophy. What is the best initial therapy for peripheral vascular disease? Most important is going to be to stop smoking and exercise, which promotes circulation. In terms of medications, you can give aspirin and silostazole. And then what else should be given in all patients with CAD, such as ACS, MI, and angina and PAD? You want to make sure that they're on statins. Supervised graded exercise program is the most useful intervention to improve functional capacity and reduce claudication in PAD patients. The single most effective medication is silostazole. Headaches and pulsatile tinnitus due to carotid artery stenosis and secondary hypertension due to renal artery stenosis are common presentations of fibromuscular dysplasia. So headaches and pulsatile tinnitus. So pulsatile tinnitus due to carotid artery stenosis and secondary hypertension due to renal artery stenosis are common presentations of fibromuscular dysplasia. Accompanying bruits are found in the neck and abdomen. Treatment of SVT we're up here now. Treatment of SVT in hemodynamically stable patients is going to be adenosine, high yield. That's going to be adenosine. Dilated cardiomyopathy will produce systolic heart failure. Ejection fraction is going to be decreased, so less than 55%. So remember, dilated cardiomyopathy will produce a systolic heart failure with a decreased ejection fraction. What level does a second degree Mobitz type 2 heart block typically occur at? It occurs below the AV node at the bundle of His. Nitroprusside is used to treat hypertensive emergency. Cyanide toxicity is a side effect of nitroprusside, so you want to look out for that in the question stem. And then the metabolism of nitroprusside releases cyanide and nitric oxide, and this is most commonly seen in patients with renal insufficiency. In the question stem, you want to look out for things like altered mental status, lactic acidosis, and neurological change such as coma or seizures. Remember that cyanide inhibits the ETC and causes the shift to anaerobic glycolysis, and contains 5 cyanide groups. There's rapid conversion to cyanide in thiocyanate, which is eliminated by the kidneys. So that's why if a patient has renal insufficiency, then they're going to retain the cyanide, and then there's a possible chance of cyanide toxicity. Next question is, what is the likely diagnosis in a patient that experienced a syncopal episode while urinating with normal cardiac examination? That would be situational syncope. So it's not vasovagal, it's going to be situational syncope here. What is paralysis paradoxus? This is when the systolic blood pressure falls greater than 10 millimeters per mercury during inspiration. Normally it falls less than 10 millimeters per mercury during inspiration. It's associated with cardiac tamponade number 1, COPD, and asthma. So think about airway diseases, obstructive airway diseases, as well as cardiac tamponade. What hematologic complication is associated with nitrates? That would be methemoglobinemia. It's also associated with local anesthetics. What is the treatment of choice for peri-infarction pericarditis? That would be supportive. NSAIDs are typically avoided versus Dressler syndrome where they're given. What is the workup of a stable and unstable aortic dissection? Initial test is going to be chest x-ray, which should show mediastinal widening and tracheal deviation. If they're stable, you want to do a CT angio to locate how bad the aortic dissection is. If they're unstable, if they have a contrast allergy, if they have renal dysfunction, you want to look for the TEE, which reveals the intimal flap. What is the recommended reperfusion therapy for patients with NSTEMI that present within 12 hours of symptom onset but cannot undergo PCI? That would be fibrinolysis. Remember that fibrinolysis is associated with not as good outcomes as PCI, so you want to do PCI, but if you can't do PCI, then you can do fibrinolysis. Perivalvular abscess should be suspected with the development of conduction abnormalities in patients with infective endocarditis. So super high yield, if they have like AV blocks or things like that, then and the patient has infective endocarditis, then the answer would be perivalvular abscess. And then which valve is most commonly involved? That would be the aortic valve. Okay, so Kussmaul sign is an increase in JVP on inhalation. What diseases in this finding what diseases is Kussmaul sign associated with? It's associated with constrictive pericarditis as well as restrictive cardiomyopathy. Next point, there are multiple disorders that can cause high output cardiac failure. I put a typo here, I meant to put failure. So AV fistulas can produce high output cardiac failure, which is an increase in cardiac output to meet the requirements of peripheral tissues for oxygen. But then what can happen is that if you have too much pumping of the blood and then it pumps too fast, then what happens is that you don't get a good amount of blood coming out because you have a good amount of blood coming out, but it's just not meeting the requirements because of, I forgot how this works actually, so I'm not going to go into it, but just memorize that this is AV fistulas are associated with high output cardiac failure. Other causes of high output cardiac failure are wet beriberi, Paget disease of the bone, mitral regurgitation, aortic insufficiency, pregnancy, chronic anemia, and what is the diagnosis in an ischemic cardiomyopathy patient on antiarrhythmics that presents with progressive dyspnea, non-productive cough, bilateral infrastructure X-ray without JVD or peripheral edema? That would be amiodarone-induced interstitial pneumonitis. And that usually occurs within months of starting therapy. So in my previous video, I went through all the side effects that amiodarone causes, so be aware of all those side effects because they can be easily tested. CHA2DS2-VASc score is associated with thromboembolic risk assessment in patients with non-valvular AFib. If it's a score of 0, then you don't want to give any treatment. If it's a score of 1, then you want to do anticoagulation / aspirin. If it's 2 or greater, then you want to do anticoagulants such as warfarin or NOACs. So that would be apixaban, rivaroxaban, and dabigatran. Ventricular aneurysm is a post-MI complication, days to 3 months, consisting of thin fibrotic myocardium in remodeled areas affected by STEMI or transmural MI. And the EKG finding, high yield, is going to be associated with persistent SC segment elevation with deep Q waves after a recent MI. And the complications include heart failure, arrhythmias, and mitral regurgitation. Distortion of the LV geometry results in papillary muscle dysfunction as well as mural thrombus. In addition to statin therapy, what is the recommended management for a patient with known cardiovascular disease and a triglyceride level of 465? That would be lifestyle modification. So lifestyle modifications such as weight loss, exercise, or decreased alcohol intake. Fibrates, you don't give them unless it's greater than 1,000. So if there's gemfibrozole, you wait to do gemfibrozole, you have to do lifestyle modification first. If there's no known CVD, then you just do lifestyle modifications. What is the likely physiological cause of isolated systolic hypertension in an elderly patient? That would be increased stiffness of the arterial wall. What are the 3 causes of acute mitral regurgitation post-MI? That would be ischemic papillary muscle displacement, papillary muscle rupture, and LV aneurysm. So those are the 3 causes of acute mitral regurgitation post-MI. What physiologic changes occur acutely? Increased LA and LV filling pressures. What is the primary mitral valve abnormality in patients with hypertrophic obstructive cardiomyopathy? That would be systolic anterior motion of the mitral valve. What are the preferred initial managements for symptomatic patients with hypertrophic obstructive cardiomyopathy? That would be beta blockers. Verapamil or disopyramide can be used as additional therapy in patients with persistent symptoms. Beta blockers decrease the heart rate, which increases diastole, which increases filling, and then that decreases obstruction. What is the EKG finding associated in patients with basospastic transmetal angina? That would be ST segment elevation. Diagnosis is reversible ST segment elevation on EKG. Coronary vasospasms on angiography confirm the diagnosis. There's no troponin elevation. You can treat it with CCB or nitrates. Avoid beta blockers. Also high yield to note, a water bottle cardiac silhouette on chest X-ray is seen in patients who have large pericardial effusion. Patients with supravalvular aortic stenosis who have can have exertional angina due to what other associated cardiovascular anomaly? That would be coronary artery stenosis, which can present with angina due to increased myocardial oxygen demand. Concentric hypertrophy is seen with diastolic heart failure. What is the initial management for a patient with suspected acute arterial occlusion leading to an immediately threatened limb? That would be anticoagulation, very high yield, and that will show up in your test for sure. Should be done prior to further evaluation with non-invasive or invasive imaging. What chest X-ray finding is often found in patients with coarctation of the aorta? That would be notching of the ribs. They may also have 3 signs due to indentation of the aorta with pre- and post-stenotic dilation. What are the cardiovascular manifestations in acromegaly? That would be hypertension, cardiomyopathy due to hypertrophy and cardiomegaly, heart failure, and valvular disease. What drug classes are useful for reducing calcium channel blocker induced peripheral edema? That would be ACE inhibitors and ARBs. Ascending aortic aneurysms are most often due to high yield, cystic medial necrosis due to aging and connective tissue disorders. What is the common vascular phenomenon seen in right-sided endocarditis? That would be septic pulmonary emboli. So splinter hemorrhages, Janeway lesions not typically produced on the right side. You see septic pulmonary emboli. What is the recommended screening for patients who smoke for abdominal aortic aneurysm? One-time screening of the abdominal ultrasound between ages 65 to 75. And we're almost done here. Takayasu arteritis is a large vessel vasculitis that commonly affects young Asian women and affects the aorta and primary branches, producing pulseless disease. Management of patient with low pretest probability of CAD, no further management. Patient taking warfarin with signs of bleeding, such as intracranial hemorrhage, suspect CYP450 inhibitors, such as NSAIDs and cimetidine, etc. And then vegetables, such as Brussels sprouts and spinach, are going to decrease the concentration of warfarin, so that increases thrombosis risk. So avoid leafy vegetables while on warfarin, I guess. Previous MI months ago, dyspnea, lower extremity edema, JVD, bibasilar crackles, ST segment elevations, that would be ventricular aneurysm. There's heart failure and persistent ST segment elevations, paradoxical bulging of the aneurysm during contraction steals, stroke volume that leads to overload, which leads to LV dilation, which leads to heart failure. Cor pulmonale is impaired function of the right ventricle due to pulmonary hypertension. Pulmonary systolic pressure is greater than 25 millimeters per mercury, which is the initial management of choice besides pain control for patients with type B aortic dissections. That would be IV beta blockers such as esmolol, labetalol, or propranolol that results in decreased heart rate, BP, and left ventricular contractility, as well as less aortic wall stress. Development of AV block in patients with IE should raise suspicion for perivalvular abscess, extending into the adjacent cardiac conduction tissues. So we talked about that earlier. If they have an AV block, then you need to be careful. And that's all. Thank you.